I'm Roshni Dasgupta. I'm the chair of the Cancer Committee. Peter Ehrlich is our vice chair. We just wanted to just give the membership a little bit of updates of what our Cancer Committee is doing and how we spend our time. It's a hardworking committee with a lot of great people who are very, very involved. Things that we've done in the past year and a half really have been pretty extensive. We've updated all the handbooks for cancer. It's on the website, so if anybody is doing a tumor that they're maybe not as familiar with the newest protocols, there's a 1-minute review for people to look at. So right before the OR, if you're going to go do a case and you want to remember what things that you shouldn't forget is, how many lymph nodes to take, what to do, there's a 1-minute review for every single tumor on the website. So all these handbooks, and if you want more details, there's an actually more extensive handbook that's also linked to the NAT chapters. There's also a very extensive website that's been completely redone by Tim Watts with really helpful links to the NCI, to the NAT, and COG protocols. So it's a great resource for you guys to have, and a lot of work went into that by Tim. Things that our committee has done in the past year and a half, we've published summary articles on what's new in Wilms tumor and neuroblastoma, which have been published in JPS. We've published a systematic review on female oncofertility and reviews oncoming with use of minimally invasive techniques for Wilms and neuroblastoma, which are going to be published very soon. We're also doing some summary and up-to-date articles on the new findings and new treatments for melanoma, rhabdomyosarcoma, and thyroid disease. Our committee is also involved in EBLAST and the NAT chapters. We have a great group of people that have been very hardworking, and we're going to hear some of their work today. This session is going to start with abstract presentations with questions after each abstract, and subsequently we're going to have video, and then there'll be 2 summary talks on what's been happening in the last 50 years for Wilms tumor and for sarcoma.
Okay, our first abstract this morning is optimization of image-guided percutaneous core needle biopsy for the initial diagnostic management of neuroblastoma. A pediatric surgical oncology research collaboration study being presented by Richard E. Overman.
Thank you. Good morning. Thank you for the opportunity to present. We have no relevant disclosures. By way of brief introduction, the Pediatric Surgical Oncology Research Consortium is a collaboration that was started in 2016. It's currently at 36 institutions in the United States and Canada, and it's committed to advancing multi-institutional surgical oncology research in pediatric patients. So accurate diagnosis and staging is key in neuroblastoma. The traditional gold standard has been open incisional biopsy, but increasingly surgical centers have used percutaneous biopsy to obtain tissue for initial diagnosis. The data has been conflicting regarding the efficacy of this, as well as the morbidity of an open biopsy versus a percutaneous biopsy. Pertinently, the key staging factors that are necessary are not only histologic features, but also biologic and genomic characterization, specifically MIC-IN copy number, loss of heterozygosity at 11q, and tumor ploidy status. Given the controversy regarding the efficacy of percutaneous biopsy, we performed a multi-center retrospective analysis of members of the Pediatric Surgical Oncology Research Collaborative. We took patients with a new diagnosis of neuroblastoma from 2014 to 2017 and performed a chart review looking at imaging characteristics, details regarding biopsy type and technique, intraoperative and postoperative complications, and then ultimately diagnostic yield of the biopsy. 220 new diagnoses during the study period were enrolled. 56 patients were excluded as they underwent an excisional biopsy instead of a preoperative incisional biopsy. Of the 164 patients that were included, 70 underwent percutaneous core needle biopsy and 94 underwent an incisional biopsy. Our demographic results are displayed here. The only significant difference was that there were more males in the incisional biopsy group. Our primary outcomes were the adequacy of the tissue specimen for primary diagnosis, as well as MIC-IN copy number, loss of heterozygosity, and tumor ploidy status. There were no differences between incisional and percutaneous biopsy for primary diagnosis and MIC-IN copy number, and both have a very high rate of successful diagnosis. It was more difficult to obtain diagnosis with a percutaneous needle biopsy for loss of heterozygosity and tumor ploidy studies. Overall, all complications were rare in both groups, and there are no differences in the complications highlighted here. Overall, in the percutaneous core needle biopsy groups, however, there were decreased complications. There were fewer transfusion reactions, a lower amount of analgesia, including opioid analgesia, and fewer patients were admitted to the hospital after their biopsy procedure. 80% of our biopsies in this study were performed by interventional radiologists, with 20 being performed by surgeons. There were no significant difference in diagnostic yield based on the personnel performing the study. In some institutions, it's standard to have a pathologist present live during the percutaneous biopsy to ensure an adequate tissue specimen. Since primary diagnosis and MICN copy number already had high yields, there was no impact of pathologists on the yield for those biopsies. There was an improved rate of adequate tissue for the loss of heterozygosity studies when the pathologists were present, but no change in tumor ploidy status yield here. Logistic regression modeling demonstrated that we had no significant effect of the number of cores or the core needle size on the diagnostic ability of the study. So in conclusion, we find that percutaneous biopsy is safe, an adequate alternative to open incisional biopsy for tissue diagnosis of pediatric neuroblastoma. We recommend that it can be used as a first line in select patients, with the caveat that it is more difficult to get these cytogenetic markers. Our results suggest that a multidisciplinary approach to these biopsies does improve yield, and finally, a prospective trial may help elucidate some of the technical factors that would improve percutaneous biopsy in the future. Thank you for the opportunity to present. I'll be happy to take any questions. And if anyone at your institution is interested in information about piecework, please contact Dr. Dasgupta with the email address here. Thank you.
Okay. This paper is now open for discussion. Please state your name and institution for the record.
Andrea Hayes Jordan from University of North Carolina, Chapel Hill. Very nice, important information. What may or may not be obtainable from the retrospective data is how many cores and what was the volume of tissue of the incisional biopsy, because the differences in the ploidy and that sort of thing may just be based on the volume of cores that were obtained versus the volume of incisional biopsy tissue. If there are some institutions that have standards for 7 or 8 cores and some that are 1 to 2 cores, and
yeah, that's a really good point. We did have data on our percutaneous biopsies for the number of cores that were obtained for most sites. There wasn't volume data for the incisional biopsies, but because of the relatively small number of percutaneous biopsies that we had that core data for, the logistic regression didn't work out to show us that the number of cores obtained had a significant effect on the diagnostic yield.
And what did you see as the range? Just curious.
It was a really broad range. So some as low as 2 or 3 and some as high as 40 cores.
40?
Yeah.
Thank you.
So along those lines, was there a minimum number of cores that you would recommend based on, look the other way, based on the study?
Sure. So certainly as we saw, there was a trend towards a larger number of cores giving more diagnostic yield. We sort of, based on this data, I can't make a specific recommendation about the number of cores. Certainly we noted in our data that it clusters towards 10 or higher cores that most institutions are performing in this study.
Well, thank you for your interesting review regarding
Can you state your name and where you're from, please?
Oh, yeah, thank you. Oscar Gomez from Spain. Thank you. Regarding the core, was there any interesting or radiological feature in the CT scan that could be indicating a specific site for the core?
It's a great question. So the data that we gathered from the initial imaging was really more about the overall size of the biopsy and then whether there was necrosis or not. We did look at those factors to see if that impacted the ability of a percutaneous core to get the diagnosis, and that didn't have any impact either. Otherwise, we didn't get down to the sort of more granular level of specific imaging characteristics that make it more likely.
Thank you.
Mm-hmm. Thank you.
David off Memphis. Just a small point. It's impressive the number of patients who had a true cut biopsy who had opioids. I mean, this is a topic that we've been inundated at this meeting and so on, and I'm not sure what to do about that, but that, it was what, on the order of 70 to 80% for a percutaneous biopsy.
One of the things that happens in a lot of these children is I think they're getting a biopsy, they're getting other procedures, whether that's a port or a line at the same time, and then they're being admitted for their initial chemotherapy. And so I suspect that some of the analgesia that you see in those children may or may not be related directly to the percutaneous biopsy.
Maybe a little bit, but none of the other things that you mentioned, I think.
Fair enough. Fair enough.
We have time for one last question.
David Rothstein, Buffalo. When we looked at NSQIP for open biopsies, we found a high rate of wound complications and bleeding, which is great to move towards TrueCut or a Corp. But are there question A, were there bleeding complications? And B, do you know of any techniques that the IR people can use as they do with liver biopsy, for example, to plug the tract or inject thrombin or something else?
Sure, certainly. So to your second point, certainly a number of these people did use something as you're pulling your introducer needle back out, whether that's a collagen plug or fibrin glue in the tract to sort of help prevent that bleeding. We don't have the sort of numbers here to make a decision about whether that seems to help or not. But yeah.
Thank you.
Great. Thank you.
Our next presenter is the imaging appearance of non-germinoma pediatric ovarian germ cell tumors does not discriminate between benign and malignant histology, to be presented by Dr. Billmeyer.
Good morning, and thank you for the opportunity to present our work. We have no disclosures. Germ cell tumors are the most common histology found in pediatric ovarian neoplasms. The majority are benign, and consequently, current emphasis has been placed on identification of factors that can discriminate benign from malignant tumors to allow ovary-sparing resections that protect fertility. Single institution series of adnexal masses have developed algorithms based on imaging appearance for differentiating benign from malignant tumors. But these series have relatively few malignant germ cell tumors in their series. There's little information regarding the overall imaging spectrum of malignant pediatric ovarian germ cell tumors in large numbers. The Children's Oncology Group study, AGCT-0132, provided an opportunity to look at a large number of malignant ovarian germ cell tumors in children. The required histology for this study included the presence of yolk sac, embryonal, or choriocarcinoma at minimum. You were allowed to have additional germ cell components, including mature teratoma, immature teratoma, or germinoma, but no pure germinoma tumors were included in this study, and no tumors that had somatic components, such as primitive neuroectodermal tumor, were included in the study. At the time of enrollment, institutions were required to submit a surgical checklist with a number of items, and among these was a descriptor of the imaging appearance of the tumor preoperatively. The study included 138 ovarian primary malignant germ cell tumors, stage 1 to 3. This was an intermediate risk study, and so stage 4 ovarian tumors are considered high risk and were not included in the study. 133 of these patients met the required histology and had completed the surgical checklist, and they formed the basis for this review. These are the demographics for the patient population. You can see that there's a fairly broad age range, anywhere from 11 months to 20 years. AFP and beta HCG were in the ranges shown, with most patients having at least one marker elevated. The tumor diameter had a mean of 16 centimeters, but tumors as small as 5.5 centimeters and as large as 33.5 centimeters were seen. The stage distribution is seen on the right side. The surgical checklist had the following options for describing the imaging appearance: either cystic with or without calcifications, completely solid with or without calcifications, or a mixed cystic and solid appearance with or without calcifications. These are the results of the imaging appearance. You can see that there were no patients that had a completely cystic tumor in this series. About 13 to 14% had a solid tumor with or without calcification, but the majority had a mixed cystic and solid appearance, which would easily be compatible with teratoma. In fact, teratoma was a frequent accompaniment in these tumors, and many of them were mixed tumors. The presence of some type of teratoma, either mature or immature, was seen in all imaging appearance categories, and overall, 54% of patients had some degree of teratoma present within their specimen. So we see that malignant ovarian germ cell tumors are frequently mixed tumors with elements of teratoma, seen in more than half the patients. The majority have an imaging appearance which is similar to teratoma. So I'd recommend always sending tumor markers, alpha-fetoprotein and beta-HCG, regardless of the imaging appearance, and approaching all of these as if there's a possibility that malignancy may be present. Peritoneal fluid should be collected at the beginning of the procedure, and all the described components of documentation and inspection for the additional factors such as omentum, lymph nodes, peritoneal surfaces, and opposite ovary should be analyzed. And you should avoid rupture of the tumor capsule.
Thank you. This paper is now open for questions.
Hayes Jordan from UNC Chapel Hill. Thanks, Deb. It came up yesterday in one of the presentations about the tumor markers and which ones to send. And it was unclear to me from that presentation, and maybe I'll ask you as well, the beta-HCG and alpha-fetoprotein are what we routinely send. But how many malignancies will we miss if we didn't send inhibin A, inhibin B, and the rest of them? Is it sufficient to just send the beta-HCG and AFP, or now should we recommend a whole panel of tumor markers?
Yeah, I think it's a good question. I think it's unknown right now. I think we've traditionally focused on those two germ cell tumor markers. Unfortunately, the germinoma has an inconsistent and nonspecific elevation of LDH, and the embryonal carcinoma has no elevated markers, so we're going to miss some of those tumors. And the inhibin levels have been kind of underappreciated, I think, for the stromal tumors, which are a not insignificant fraction of the malignant tumors. And it's currently really unknown how frequent and how reliable those will be. The current prospective study for the Midwest Pediatric Surgical Consortium is looking at sending not only all of those markers, but also CA-125 to see which ones are really helpful to us. But I think the bottom line is, for any ovarian neoplasm in a child, the risk of malignancy is somewhere around 15 to 20%, and that you should always have that worry in the back of your mind, regardless of what they look like and regardless of what the markers are.
Max Sang in Memphis. So given that last statement, Dr. Billmeyer, you give us your recommendations about partial oophorectomy and lesions that appear to be contained and normal with some residual normal ovary?
I think if you send markers ahead of time and your markers are negative and you have a clearly defined plane and you avoid rupturing the tumor capsule, it's acceptable to begin with that and then see what your findings are. I think one issue that becomes relevant is how long it takes these markers to come back. So I think sometimes you're in a situation where if you have someone present in the setting of a torsion, you don't have the luxury of knowing what your markers are. But I think if the patient comes to you electively, you do have an opportunity to have better planning if you send the markers and get them back before you do your operation.
I think the gentleman over there.
Sharif Emil, Montreal. I was just curious, if I understood your data right, you said that none of the malignant tumors had negative markers, that at least one marker was elevated. Is that correct?
So that's not correct. There were 2 patients that had normal markers out of the series.
Okay. And the denominator was how much again?
133 patients in the analysis. But I have to also point out that this protocol specifically excluded patients with pure germinoma. And so in that group of patients, which is a fairly good size proportion of the patients with malignant germ cell tumors, you are going to have negative markers.
No, I understand for germinoma, yes, but we include CA-125 and CA-19-9, although those are unclear, of unclear significance in the markers. But if all those markers are negative, it sounds to me still that the chances that tumor is malignant is not 0, but approaches 0. Just from the statistics you're presenting.
Well, germinoma is a fairly common subset of these patients, which were excluded from this protocol. So if you, independent of my data, in the broader population of patients that truly have a neoplasm, there's going to be a higher incidence of negative markers.
Thank you.
Okay, one last one. I know we can continue the discussion off the stage, but please, next.
Dr. Anderson? Yeah, Dr. Anderson. Go ahead.
Catherine Anderson from the Los Angeles area. All of those tumor markers, it's absolutely marvelous that you have those. But in the era before those were available, the ovarian sparing operation was done for what appeared to be a teratoma. Is there any information about the long-term follow-up of those patients? And did some of them develop tumors in the remaining ovary?
So are you asking me about patients who truly have benign tumors with ovary-sparing procedures?
Some of them would have immature elements in them, and that's what I'm asking about.
So unfortunately, no, there's not adequate information for many instances of immature teratoma and how it should be managed. In the adult population, they treat all ovarian teratomas with immature ovarian teratomas with chemotherapy. In the pediatric population, we don't do that, but we are lacking information on follow-up. What I can say is that there is data that suggests even with mature teratoma, if you follow them long enough, the incidence of a contralateral tumor is in the 20 to 30% range. And so initial ovary-sparing procedure for those patients with close and continued follow-up for long-term is important.
Well, I think it's extremely important to get a long-term follow-up for the mature with an immature elements, if that is possible. That would be a nice paper at APSA. Thank you.
Okay, thank you. We're going to move on. Our next abstract is use of indocyanine green as a diagnostic adjunct at the time of pulmonary metastectomy for hepatoblastoma, presented by Dr. Bondoc and team from the University of Cincinnati.
Let me ask a question.
Yeah, good morning. Yes. Thank you for the opportunity to present.
How many of these are granulosa cell tumors?
We have no disclosures. A recent epidemiologic review identified hepatoblastoma as the pediatric malignancy with the fastest rising incidence in the world. And unfortunately, 20% of patients initially present with metastatic disease, and these patients have poor event-free and overall survival. And metastasis at diagnosis impacts treatment strategy, and therefore accurate detection is essential. Indocyanine green is a fluorescent compound that was brought to market by the Kodak Corporation in the 1950s, and its medical applications for ICG were the quantitative measurement of hepatic and cardiac function. As a medication itself, ICG has a relatively benign side effect profile and favorable pharmacokinetics. The operative uses of ICG are multidisciplinary. From a general surgical perspective, ICG and its detection has been used to evaluate the vascular status of things like anastomoses, tissue transfer, as well as the viability of intestine at the time of resection or exploration. And one of the most well-described uses of ICG in surgical oncology is as an adjunct to resection and staging of a multitude of solid tumors, mostly in adults, that's published, but there are some experiences in pediatric solid tumors. In the panels on the right side of the slide, we demonstrate the view of a pulmonary metastasectomy via open thoracotomy in the color pictures, and then in the near-infrared fluorescent images, you see the lesion emitting ICG. Our center has seen an increase in the number of cases of hepatoblastoma, of which a significant cohort have had metastatic disease either at the time of initial presentation or at relapse, suspicion for relapse. And because it's critical to surgically extirpate pulmonary hepatoblastoma, we wish to evaluate the utility of using ICG as a diagnostic adjunct during metastasectomy. And during the period we started using this technology, we became aware of a specialized near-infrared capable telescope system. So we therefore also wanted to know if thoracoscopic ICG assisted resections would be possible. And therefore, the objective of the study was to determine whether or not preoperative administration of ICG prior to pulmonary metastasectomy would aid us in the identification of additional lesions. We performed a retrospective review of our experience with ICG, and we focused just initially on the diagnostic sensitivity, specificity, and predictive values of this technique. We administered ICG per a previously identified dosing regimen. In the literature, we administered 0.5 milligrams per kilogram of indocyanine green 24 hours prior to going to the OR. We made sure to obviously review our axial imaging of the chest prior to surgery, and a lesion was deemed resectable based on a combination of any of the or all of the criteria that I listed there. So either those lesions seen by direct visualization, those that were ICG fluorescent, and those that you could palpate with your hands if we did the operation via open thoracotomy. 13 patients underwent 18 operations, and at the beginning of our experience, all of the patients underwent thoracotomy due to the availability of equipment type, the handheld ICG detector made by Hamatsu, which is the one that was published by the Japanese in 2015 in pulmonary hepatoblastoma. But the most recent 8 patients we operated on all underwent thoracoscopic exploration, and their operations were completed thoracoscopically with the new telescope system I mentioned to you guys. Here, the panel on the left represents a thoracoscopic view of a lung lesion, which we refer to this type of view as the fusion view, where the standard telescopic image is merged with the near-infrared fluorescent channel, and the green that you see there in the center of the screen represents the target lesion. Using the same camera system, you can still see the fluorescence in the center of the wedge-resected specimen. I have a second that shows it a little bit better. This is still the same patient with another lesion in a different area that is sort of weakly fluorescent, but still visible under direct visualization and in the fused and the merged image. And then after resection, you can see that it is still quite positively emitting ICG. So overall, we resected 57 total specimens, 38 of which were ICG avid. 31 of these proved to be pathologically positive for hepatoblastoma. 3 of the lesions that were either seen by direct visualization or palpated manually were ICG negative but pathologically positive. And as such, the sensitivity in our small series here was 91%, but the specificity was only 61%. Overall, the patients experienced relatively short, uncomplicated postoperative courses. There was one episode of post-op tracheitis in a former preemie with bronchopulmonary dysplasia who had a chronic tracheostomy, and in the process of manipulating the endotracheal tube to get single lung ventilation, multiple passes, I suspect that had something to do with that one. But there were no surgical site infections or pneumonias, and there was one postoperative blood transfusion for a patient who was on his 3rd thoracotomy. Certainly, there were limitations to our study. It's a small population from a single center. It's retrospective, and there is some degree of operator learning curve. We changed the technology that we were using halfway through, essentially. So, in conclusion, we feel that the use of ICG in pulmonary metastasectomy for hepatoblastoma is a safe and sensitive adjunct modality. We also learned that perioperative conditions, such as the way the thoracoscope is set up, the software is set up, as well as the critical nature of using very good single lung ventilation, can affect the sensitivity of the method. In the future, we hope to develop a more sophisticated understanding of ICG's detection capabilities, including creating an animal model to tell us how large of a lesion we can truly detect, how deep these lesions can be. And we also realize that a standardized operating protocol needs to be developed to facilitate prospective study of ICG use in pulmonary metastasectomy. We plan on performing such a study in a multi-institutional fashion through the Pediatric Surgical Oncology Research Collaborative. There is also data in adult literature about using ICG as a therapeutic carrier, not only as for fluorescent treatment or sort of radiation treatment, but also could you tag a therapeutic agent to ICG and deliver it directly to these lesions. Thank you for allowing me to present, and I'm happy to take any questions.
We have time for one question.
Oh.
Dr. Davidoff?
Davidoff, Memphis. Very nice, Alex. Nice presentation, something that is very exciting and I think definitely is here to stay. I'm interested in your comments on the false negatives and the false positive. In particular, the false negatives. Did you study them on the back table to see maybe it was just a depth problem or something, and in fact they were fluorescent? What were the reasons?
Right, specifically for the false negatives. So we had those 3 false negatives. Interestingly, they still fluoresced on the back table, but when we looked at them pathologically, so let me start with the false positives. The false positives still fluoresced, but I think that was part of the learning curve, trying to understand better what exactly, because you can you can toggle through 3 separate views, that fusion view, but then the pure near infrared on the thoracoscopic version actually is a totally black screen, and when it's fluorescent, it's white. And so I think some of it is the thoracoscope settings and then what we actually see. So oftentimes 2 of us or 3 of us were in the operating room looking at the images, and even if we see slight white when you turn to that highest resolution, we called it positive, and so it still looked positive when you toggle through those channels for the false positives. For those false negatives, interestingly enough, those lesions had low Ki-67 markers on immunohistochemistry post hoc, and so we speculated that they were either very marginally viable tumor, but again, that would be speculation.
Okay, thank you very much. Okay. Go ahead, Kristen.
All right, so this tribute is for Dr. Othersen. He's in the audience, and we'll have him stand at the end to be recognized.
I was born in Charleston, South Carolina, right here in downtown Charleston, 1930. I always liked to do things with my hands. I like to fix things. And when I was a senior resident, I noted that I liked taking care of children in the hospital. And I read a book entitled The Surgeon and the Child. It was a little book, just a small book, but it gave not only some technical details about the diseases in children that pediatric surgeons treated, but it also was a very empathetic book. It really showed the heart of a pediatric surgeon. And one of the chapters was entitled With No Voice But a Cry. And I was really moved by that book, and I was convinced then that I wanted to go into pediatric surgery. Eventually ended up in Columbus, Ohio, at the Children's Hospital there, training with Dr. H. William Clatworthy. And it was tough work. Well, I had left to go to training in pediatric surgery. I had asked all the surgeons in Charleston whether they thought a pediatric surgeon could come back and make a living, and they all told me no. When I came back to Charleston, I looked at what needed to be done. There was a lot that needed to be done in children. In fact, we had to not only take care of the children, but we had to educate the pediatricians as to what a pediatric surgeon was. We treated a lot of children with neuroblastoma. Shortly thereafter, I had a patient who had been operated on by another surgeon in town, a good surgeon. This patient had a very large neuroblastoma in the abdomen, and he was not able to remove it. He just took a biopsy, and he told the patients and the family that the child would not make it and would just go home to die. The child had received radiotherapy as a treatment for the neuroblastoma, but after that was completed, then I reoperated on the child and removed the tumor, all remaining tumor. It was a huge operation. She's now 40-something years of age. Well, I'd always been interested in childhood cancer as part of my training, and this patient that I had early in my practice with the neuroblastoma really established one of the big interests of mine. And in fact, that was the reason I went to spend a year in Boston, was to learn something about immunology, hoping that immunologic therapy combined with surgical therapy would be the answer to tumors like Wilms tumor and neuroblastoma. I was part of the group that set up the protocols for this national Wilms tumor study, which was actually one of the first multidisciplinary cancer study groups, and it sort of set the stage for the other groups that followed. And we found that the surgeon was key in this group. We've made tremendous strides in Wilms tumor and neuroblastoma. We still have some that we can't cure, but I would like to see us develop that same ability to treat the solid tumors as the leukemia patient.
So Dr. Othersen is still active in South Carolina, and he actually teaches the residents every week in sessions called the Beehive. So if he's in the audience, we'd like to stand and recognize him.
We're going to go on to our next portion of the session. We're going to have updates on what is new in Wilms tumor, and Dr. Marcus Malix can present.
Good morning. I'd like to start by thanking the program committee and the leadership of the Cancer Committee for giving me the opportunity to present the really tremendous accomplishments in Wilms tumor therapy over the past several decades. I'm also hoping to highlight the pivotal role the pediatric surgeon has played I need this thing, right? In those accomplishments over the years. So I'd like to start with a case to sort of highlight the progress that we've made. The patient's a 4-year-old male that had favorable histology Wilms tumor. There was tumor extension up to the atrium, as you can see here. The patient had stage 4 disease with a metastatic lesion in the lung. He was shown to be a rapid responder, and also was LOH negative at 1P and 16Q, and had no evidence of 1Q gain. So in the 1950s, this patient would have a 100% mortality. In 2019, this patient has a 5-year event-free survival of 88% and an overall survival of 92%. So how did we get here? So the tumor is named after Max Wilms, a German pathologist and surgeon, who published this textbook in 1899, essentially showing that the tumor cell of origin is something that's found during the development of the embryo and fetus. I'm not going to attempt to pronounce the title of the textbook, but essentially it translates to mixed tumors of the kidney. The first reported treatment of Wilms tumor was in 1916. This occurred at Cincinnati General Hospital. It was a 4-year-old boy with a large Wilms tumor who was considered a hopeless case. He received several treatments of radiotherapy, and they saw a marked reduction in the size of the tumor. The child, unfortunately, of course, died, but it did show that radiotherapy may have some effectiveness later on in the treatment of Wilms tumor. Surgery was recognized early on as the first effective treatment for Wilms tumor, but the operative mortality was quite high. Dr. William Ladd presented his outlines for the surgical principles for treating Wilms tumor, the radical nephrectomy. And by sticking and adhering to these concepts, he actually was able to show for the first time some reportable survival in Wilms tumor. He reported 31%. Prior to that, the best survival was in the single digits. So this was the first step towards finding treatment for Wilms tumor. Fast forward now to the 1950s, Sidney Farber was experimenting with chemotherapeutic agents and identified a number of them that had activity in animal studies. He started using them in patients, and he published in 1966 on the effect of chemotherapy in Wilms tumor. He was using dactinomycin at the time of surgery along with radiotherapy. He stated in that article regarding chemotherapy, the assumption was made that the clinical agent carried throughout the body by the bloodstream might destroy small foci of tumor before solid implantation and further growth could take place. His results were staggering. 89% disease-free survival at 2 years. The previous best reported results were 40%. He more than doubled that. 58% survival of patients with metastatic disease. Previously, there was no reported survival in patients with metastatic disease. Shortly after that came the National Wilms Tumor Study Groups. Their first meeting was in 1968, and they enrolled their first patient in 1969. Over 30 years, they had 5 large studies. The group was led initially by Giulio D'Angio. It was very multidisciplinary, and everybody's opinion was valued. The initial surgeons were Harry Bishop, Lucian Leap, and Willard Goodwin. You just saw us pay tribute to H. Biemann Othersen. He was very involved in NWTS 2 and beyond, and he stated regarding the mission of these studies, the plan was to develop therapy which could be implemented in a systematic and randomized fashion with standardized protocols. The outcomes could then be studied in order to determine the best therapy for children with Wilms tumor. All in all, they treated almost 10,000 patients across these 5 studies, which is amazing considering the incidence is only about 500 to 600 per year in North America. What did they find? They basically determined what to treat Wilms tumor with, how long to treat it for, and what to treat stage per stage. They also were able, by the mid-1990s, to show a survival of over 90% for Wilms tumor. At a very similar time in Europe and other places around the world, the International Society of Pediatric Oncology formed. They enrolled their first patient in 1971. What's very interesting about this, and I didn't realize this until I started looking into this stuff, we all know they treat Wilms tumor upfront with chemotherapy. That was actually a philosophy in place from their inception. The very first paper they published was on the use of radiotherapy for Wilms tumor, and they reported on how there was a reduced rate of intraoperative spill. The next study, which I showed here, was that showed preoperative chemotherapy also reduced the rate of intraoperative spill and reduced the number of patients that required radiation. What's very interesting, looking at PSYOP and NWTS, COG, you can see that it's just a sophisticated way to demonstrate there are a number of different ways to treat disease and still have excellent outcomes. So the patient that I presented earlier on had tumor thrombus up to the atrium. The question, that was obvious here that needed to be answered is, what do you do about those patients? So Dr. Robert Schamberger in 2001 published on that. He reviewed cases in NWTS4 and found that really the hepatic veins were the key. Tumor thrombus above the hepatic veins, if you tried to operate on that up front, the complication rate was higher and the complications were more severe. Therefore, but with tumor thrombus below the hepatic veins or just in the renal vein, those patients did very well with upfront resection. So I mentioned over 90% survival. How do you improve on that? So you have to find subgroups of patients that are not doing poorly, that are in that 10% that are not doing well. And so biology is obviously very important there. It was suggested that LOH at 1P and 16Q in previous studies was important. So in NWTS5, they prospectively looked at that and identified that certainly for higher stage patients that had combined LOH, they had worse outcomes. Here, the 4-year event-free survival was 66% for those patients. By comparison, if they didn't have LOH, 91% for stage 3 and about 80% for stage 4. So they took this subgroup, increased therapy on the next COG trial, and they were able to increase the event-free survival by 30%, up to 96%, just by recognizing those markers of poor outcome. Another way you can improve outcomes is by trying to decrease therapy for patients who don't necessarily need that level of therapy. So NWTS 1 through 4, there was a group of patients that no matter what we gave them, they did wonderful. They had over 95% survival. So they took that group of patients in NWTS5 and called them the very low risk group. You can see who they are here, and essentially just treated them with surgery alone. What's interesting is they actually stopped the trial early because the event-free survival or the relapse rate was actually unacceptably high early on. Of course, they continued to follow those patients and saw that the salvage rate was higher than was expected. So the overall survival was still 98% for those patients. On the next COG trial, the overall survival for those patients was 100%. So what they showed here, what Dr. Schamberger and his group showed here, was that you can avoid chemotherapy for a majority of patients with a maintenance of excellent overall survival. Another important question to answer was the patient with lung mets. So you have a patient with lung mets, they get chemotherapy, the lung mets are gone. Do you still radiate their chest? This is an important question because the late effects trial showed that 15% of patients with Wilms tumor, 15% of female patients with Wilms tumor will develop invasive breast cancer before age 40. So if you can not radiate the chest, it's obviously a very good thing. So those are called rapid complete responders, the ones who respond in the first 6 weeks. Even after eliminating radiotherapy for those patients, they still had a 4-year event-free survival of 80%. The incomplete responders, they actually took that to be a surrogate for a bad-acting tumor, and they actually increased therapy for those patients. And in that group, were able to show a 3-year EFS of 88%. To compare, the most recent NWTS trial, where they got standard chemotherapy and all patients got lung XRT, the 4-year EFS was 75%. So by reducing therapy for one group and increasing therapy for another group that seemed to have worse disease, they actually were able to improve survival for both groups and limit radiotherapy. The final study I wanted to discuss today was actually the first prospective study on bilateral Wilms tumor. So Dr. Ehrlich spearheaded this trial, and essentially what he noticed was that bilateral Wilms tumors had much worse survival numbers than their unilateral counterparts. So the 4-year EFS was 56% for bilateral Wilms tumor, even though many of them have favorable histology. One other thing that was noted was that there was no standard duration of preoperative therapy. There was no standard therapy itself. Some of these patients received almost 1 year of chemotherapy before going to surgery. So what they found simply by standardizing management was a 4-year EFS of 82%, up from 56%, and that 84% of patients were able to have surgery by week 12. One thing that we can do better on is that there was only 39% of patients that had bilateral nephron-sparing surgery, meaning parts of both kidneys were left behind. So what are our future directions? We've obviously come a long way. We've done wonderfully with Wilms tumor, but there's obviously more room to go here. We hopefully can expand the very low-risk Wilms tumor group, the surgery-only group. We need to standardize lymph node recommendations and prospectively collect outcome data on that. There's still a lot of heterogeneity in terms of the number of nodes that are taken and where they're taken from. 1Q gain, which I didn't really touch on, it seems to be a very powerful predictor of outcomes, so there's a lot more to do in terms of studying that. And with bilateral Wilms tumor, as I said, we really need to improve our rate of nephron-sparing surgery, and we need to look at the biological factors as well in bilateral Wilms tumor. Once again, thank you for the opportunity to be here today.
Right on. Thank you, Marcus. An excellent talk. Our next talk is by Dr. Timothy Lautz from Chicago, looking at Rhabdomyosarcoma, 50 years of progress through cooperative studies.
Thank you, Dr. Ehrlich. It is my pleasure today to present on behalf of the APSA Cancer Committee on the topic of Rhabdomyosarcoma, 50 years of progress through cooperative study. 50 years ago, at the time of APSA's founding, 3/4 of children with rhabdomyosarcoma would die from their disease. The rare survivors came from the 25% of patients who had fully resectable tumors. During the 1960s, the efficacy of single agents was documented, but it wasn't until Wilbur et al. Began giving the combination of VAC therapy that survival benefits were shown. The intergroup Rhabdomyosarcoma study group was formed in the early 1970s, and this paved the way for 5 decades of cooperative study. This began with IRS and proceeded through the Soft Tissue Sarcoma Committee of COG. Between 1972 and 1997, IRS enrolled over 4,000 patients on 4 different studies. During this time, 5-year survival improved from 55% to 71%. However, the group studied multiple different chemotherapy agents and found no benefit compared to standard VAC therapy. However, multiple other lessons were learned from these first 4 studies, including important local control questions. We learned that re-excision of incompletely excised tumor is beneficial if form and function can be preserved, that the eye, vagina, and bladder can usually be saved, that radiation can be omitted for children with localized, completely excised embryonal rhabdo, and that most patients with alveolar rhabdo have a tumor-specific translocation. Finally, we learned that mature rhabdomyoblasts are common after treatment of bladder rhabdo and are not necessarily malignant. A better understanding of risk stratification has been one of the key breakthroughs during the past 50 years. We now understand that there are multiple key pieces making up the risk stratification puzzle, and these include histology, clinical group, location, size, age, nodal status, fusion status, and whether or not there's metastatic disease. By putting these pieces together, we can assign a risk group, and this risk group reliably predicts outcome and forms the basis for stratifying patients on the recent and current studies. Beginning with IRS-5 in 1998, the studies were stratified by risk assignment. For the low-risk group, the goal was to reduce therapy while maintaining excellent survival, and this proved feasible. In the intermediate group, yet another chemotherapy agent, this time topotecan, was studied and showed no benefit compared to standard VAC therapy. However, in the high-risk group, there was some additional benefit to the addition of irinotecan. After the inception of COG and the transfer of studies into the Soft Tissue Sarcoma Committee, this model of risk-stratified study was continued. For patients with low-risk disease, further refinement of risk classification allowed for improved survival with further therapy reduction. For those with intermediate risk disease, VAC-VI had comparable outcomes, but with reduced toxicity when compared to standard VAC therapy. However, this intermediate risk study demonstrated the potential downside of therapy reduction. Although results were comparable in both arms of this study, when you compared the results to historical controls, the older D9803 study, both event-free and overall survival were worse. There were several possible explanations for this, but the most likely culprit is the reduction in the cyclophosphamide dose. And you can see in this graph the cyclophosphamide doses over the different studies. Other possible contributors could include a de-emphasis of delayed primary excision, as well as changes in the radiation timing. The current intermediate risk study is investigating the benefit of adding the mTOR inhibitor, temsirolimus, which has showed promise in earlier phase studies. And the recently completed high-risk study showed no benefit with an altered chemotherapy regimen. However, COG is not the only study group addressing this important topic. Other breakthroughs have come from the German study group, the European Soft Tissue Study Group, and the International Society of Pediatric Oncology. Most notably, EPSSG recently demonstrated improved event-free and overall survival with the addition of maintenance therapy at the end of standard treatment. This was one of the first real chemotherapy breakthroughs in recent decades, and this component was recently amended onto both arms of the current COG intermediate risk trial. Next, we will hone in on progress in local control for rhabdo. It is first important to understand the nomenclature of the different surgery time points. Oftentimes, primary excision is performed prior to establishing the diagnosis. In these cases, primary re-excision can be performed to achieve negative margins, and clinical group is determined after PRE. In some cases, delayed primary excision can be considered after 12 weeks of induction chemotherapy. Although DPE doesn't alter the clinical group, it can allow for reduction in radiation dose, as we'll talk about in a moment. Excision of residual mass at the end of therapy is generally not indicated because it is associated with significant morbidity without any documented survival benefits. Remember that residual mass at the end of therapy does not necessarily equate to viable tumor. Each of the recent intermediate risk studies has addressed a specific local control question. In IRS-4, there was no benefit to hyperfractionation of radiation therapy when compared to standard once-daily treatments. The role of DPE was addressed in D9803, and I'll talk about that momentarily. In 0531, we studied the benefit of earlier initiation of radiation at 4 weeks, as is often done in several head and neck tumors, and showed no benefit to standard timing at 10 weeks. I'd like to go back to the benefit of DPE. This was considered in D9803 for patients with bladder dome, trunk, and extremity tumors. Most patients were able to achieve R0 and R1 or R0 or R1 resections and thus have a reduction in their radiation dose with very comparable outcomes compared to patients who did not have DPE and had full dose radiation. Besides these important lessons, there have been other valuable local control nuggets gleaned from the past 50 years of studies. We now know that over half of operative bed recurrences occur in patients who did not receive protocol RT, that size greater than 5 centimeters is the biggest contributor to local failure, and that response status at the end of therapy for group 3 patients is not associated with failure-free survival or death. We have also gleaned important nuggets about regional disease. We know that regional lymph node status alters prognosis for alveolar, but not embryonal rhabdo, that boys older than 10 with paratesticular rhabdo are more likely to have retroperitoneal nodes, and that sentinel lymph node biopsy has better sensitivity and specificity when compared to FDG PET for tumors involving the extremities. In many ways, the evolution of surgical practice over the past 50 years has shown that less is more. We have learned to avoid amputation and pelvic exoneration. We have learned that for some patients, radiation can be definitive local control and no surgery is required. It has been shown time and again that debulking surgery for rhabdo is not beneficial. Biopsy has become less invasive with the advent of percutaneous core, and we have learned to avoid radical end-of-therapy resections. However, we have also identified some areas where we can do more as surgeons to benefit our patients. We have shown the benefit of sentinel node biopsy and learned to utilize brachytherapy for female GU tumors. We have demonstrated the value of multidisciplinary preoperative discussions and the importance of fertility preservation, consultation, and procedures. Safe surgical resection has been aided by new technologies like nerve monitoring, and emphasis on protocol adherence has helped to improve outcomes. I'm going to leave you with one random tidbit. We have also learned that an incomplete immunization schedule and incomplete DPT schedule particularly are associated with an increased risk of rhabdomyosarcoma. So with that, I thank you, and I don't think we have time for questions.
Go ahead.